as was already said, it can occur at any age, but most are older people above 50. And so the features are those you can also see with pancreatic cancer, abnormal pain, weight loss, painless obstructive jaundice. And recurrent cholangitis may precede the diagnosis by several months. This has already also been said that there are two types, type 1 and type 2, but it's important to realize that these are really different diseases that have in fact nothing to do with one another. They have different clinical and histological features. So this has also been shown, an overview of the clinical features. I will the most important one show here. Yeah, type 2 can also occur in children, which is not seen in type 1. Then the serum IgG4 elevation seen in the large part, but certainly not in all type 1 patients, so not in type 2. So type 1 is the IgG4 related disease, which is not the case for type 2. Organ involvement, looking for it, can be very helpful for coming to a definitive conclusion. This is not the case in type 2, where you just have in up to 30% IBD. Then presentation, yes, there is a lot of overlap, relapses. This is common in type 1, but rare in type 2. So why then they are classified together? Because of the important fact that both are steroid responsive. So it's important to recognize them and to avoid surgery. Then radiology, there is also overlap, so it can be a diffuse sausage-like swelling, like already said, with that low attenuating peripancreatic rim, or it can be several focal lesions, or sometimes only one focal mass. And then also important, this has been shown, the irregular narrowing of the duct. So needless to say, if you have one big mass, it can be truly difficult to make the distinction of pancreatic cancer. So this has been shown. These are the ICDC criteria, the histological part, where, if we want to diagnose it preoperatively, they made criteria for type 1, type 2. I will come back to that immediately. And you have the level 1, which means that, you can get a definitive diagnosis with these features. With level 2, this is not the case. However, this has also already been said that for type 1 autoimmune pancreatitis, you can, in combination with the clinical features, radiology, serological values, you can get a definite diagnosis of autoimmune type 1 pancreatitis. You, in several cases, don't need tissue. So now I will focus on the histological features. So first for type 1 autoimmune pancreatitis. And in the acute and subacute phase, you typically have these 4 features: diffuse lymphoplasmacytic infiltrate, I show immediately pictures, the storiform fibrosis, the obliterative phlebitis, phenylitis, and then many IgG4 positive plasma cells. Now, need to be said that these individual features on their own, they are not specific for IgG4-related disease, but if you have a combination, then you can reliably and reproducibly make the correct diagnosis. However, that is for the acute and subacute phase, but sometimes you're in the late phase, for example, because of late referral of the patients, and then you get less inflammation and you get more patchy inflammation and more fibrosis. And then, of course, it becomes much more difficult, not on resection specimens, but on biopsies, to make the correct diagnosis because the typical areas may not be present in the biopsy. On HNA, you will not find the vein, and so you have to do an elastin stain. You recognize it filled with inflammatory cells. But again, in older cases, it becomes more fibrotic, less inflammatory cells, and then it's like an obliterative vein that you can find in any type of chronic pancreatitis. Here there is still one. And of course, rarely you have also the connective tissue diseases with vasculitis, phenylitis, so also not 100% specific. Important, a huge number of IgG4 positive plasma cells, and the ratio is important. It should be above 40%, but more and more, the awareness against overemphasizing these IgG4 positive plasma cells. So it appears more and more that it's less specific for type 1 autoimmune pancreatitis, and initially thought it may be present in other non-neoplastic as well as neoplastic conditions. And what are then the false positives? Usually the value is about 10 per HPF, but it's generally only patchy. And then the ratio is above 40 or around 40, but not like in the very typical cases where it's usually 70 to 80%.
I have a question, and actually it's more than a comment. When we have this mass form that we think that might be EG4, but we don't have the histology to support our findings, what do you do? Do you usually start, like Stefano, you usually start with steroids to see, like you exclude malignancy, but how long do you follow these patients up?
Yes, the steroid trials can be used in doubtful cases. Should be 4 weeks, no more. The most important thing is to not do a low dose of steroids. It's 1 milligram per kilos. Otherwise, it's only confusing much more than before, because you don't know if there is not a response or if there is a response. The dosage of the steroids is really important. Must be done. You must done a good steroid trial.
Okay, thank you. And if it still persists the doubt because the response was not that good, do you follow up and with imaging? How do you do it in this case?
I think we should repeat biopsy, obviously, because one negative do not exclude the possibility of a cancer. So a second biopsy, I think, is mandatory. And if we still believe that is autoimmune pancreatitis, we can continue with therapy. And we have, for example, another MRI after 2 months.
Okay.
Yeah, and see what happens.